everyone out there who's in the audience tuning in today. We're super excited to be here. So I will get us started with our objectives. So by the end of our talk today, hopefully we will have reviewed the very broad spectrum of causes for early psychosis. We will be focusing on learning some of the key details in history and the clinical examination to obtain in order to narrow down a differential for early psychosis. And then we're also going to talk a bit about understanding the fluidity of differential diagnoses and the need for reassessment, ongoing reassessment over time. So we are just going to start with a question. And I think this is a new feature for us, so bear with us. Hopefully this will work okay. So which of the following choices does not present with psychotic symptoms? And we'll give everyone a moment to consider this. Okay, and Laura, do we stop the question or? Let's see. Okay, so a pretty wide range of answers. Awesome. So the correct answer here is actually hypomanic episodes, choice B. So according to the DSM-5 and what we know clinically about hypomania, hypomania is not associated with any psychotic features. Classically, if any psychotic features in a mood episode exist, like within a potential manic hypomanic situation, if there are any psychotic features, then the mood episode would be considered mania. All of the other answer choices could have features of psychosis. One that is not listed that could also have features of psychosis is actually dementia as well. So this leads into our first objective, reviewing all of the different range of possible etiologies for psychosis, including early psychosis. So we have quite a few of them, as you can see here. And this is a somewhat overwhelming slide, but we're going to break it down a bit. We're not going to go into detail on, of course, every single diagnosis on this slide, but we will be talking about quite a few of them. So when we're thinking about differentials for early psychosis, of course, we always want to consider what we call primary psychotic disorders, such as schizophrenia or schizoaffective disorder, which are also considered non-affective or non-mood related disorders. The other big category of diagnosis for early psychosis can include primary mood or affective disorders, primarily bipolar disorder with psychotic features or major depressive disorder with psychotic features. And I'll turn it over to Dr. Meidl to discuss some of the other ones listed here.
Yeah, thank you, Dr. Yakoob. And so in thinking about the next category, that is personality disorders. And I did just want to highlight with these because, the names of them can be really similar to schizophrenia and can be sometimes hard to parse out. And so with schizoid personality disorder, what that really defines is patients that have a lifelong pattern of social withdrawal. They're often perceived as eccentric or reclusive, but challenges with social connection is really key here. And there can be challenges with affect as well. And a key is that there isn't a desire necessarily for a closer relationship. And then schizotypal is also one that can really look similar to some of our primary or early psychosis syndromes. And with schizotypal, there's more of a pervasive pattern of eccentric behavior as defined and peculiar thought patterns. And their patients may often struggle with specific social deficits or cognitive distortions, and they'll have challenges with things like odd beliefs or ideas of reference, unusual perceptions, magical thinking. And they'll have these without a specific psychosis, but often have a first-degree relative that may have a psychosis disorder. And we're happy to talk about that a little bit more because that can be something that's confusing. But really, it's characterized more than odd beliefs than a psychosis syndrome with perceptions outside of reality. And then paranoid personality disorders is also something that commonly comes up and is often a question. And a key with paranoid personality disorder is there's a general distrust of others, beginning by early adulthood, and it's present in a variety of contexts. And often patients will have suspicion, preoccupation, um, challenges with interpreting something as threatening when it may not be, but they won't have other features of psychosis beyond that paranoia. And then last is borderline personality disorder. And this is outside of that cluster A group of personality disorders. This patients with borderline personality disorders really have emotional instability and challenges with interpersonal relationships as well. There can be fears of abandonment, chronic feelings of emptiness, things like that. At times, there could be paranoia. Um, and that can lead to some confusion of, is this a psychotic disorder or is it not? So happy to talk more about that as well. And then there's this category of other. And for other, there is attenuated psychosis syndrome. Now that is something that our Prime clinic really is a wonderful clinic if you're worried about this. But this is a syndrome that's characterized by subthreshold psychosis-like symptoms. These could be positive symptoms like perceptual or cognitive disturbances. It can also have some negative symptoms like anxiety or flattened affect, and things like that. But it doesn't reach the threshold of psychosis. And that's a really key difference between a true psychotic disorder. And sometimes people do not develop a psychotic disorder. They are a part of the Prime clinic and never require referral to a clinic that focuses on psychosis. There's substance and medication-induced psychosis, which we'll talk about a little bit more on another slide. And then there are psychotic disorders or psychotic episodes that can be a part of other medical conditions. Examples of these are things like dementias or delirium. So you can have psychotic symptoms and episodes associated with these. And we'll talk more about this on another slide as well. There can be psychosis-like phenomenons that can happen as a part of PTSD that are not that do not quite reach the threshold of a psychotic disorder. You know, there can be things like perceptual disturbances that may be related to the trauma, and that's the sort of thing that we're thinking about with that. Dissociative disorders is something that also can become a common confusing point. And I'm so happy to talk about that if anybody would like to a little bit later. Similarly, obsessive compulsive and related disorders, things like body dysmorphia and things like that, that can be something that also comes up in this differential diagnosis.
Absolutely. So, for the rest of this talk, we're going to be using a clinical case, which we've abbreviated as CC. We're going to intersperse details about this case throughout as we continue to explore some of the key details of history to obtain on a clinical examination for early psychosis. So, our basic vignette is that we have a 19-year-old male psychiatrically admitted for the first time after an aborted suicide attempt via carbon monoxide poisoning. He has a known history of depression and anxiety and recently broke up with his girlfriend. While admitted, he disclosed to the inpatient team that he felt like life was a simulation. His parents may be actors. He had concerns about all humans on Earth being machines. Other than that, he denied hallucinations. So I want to open this up to the audience, and this will be another kind of question form that we will bring up. But for this case, at this point in time, what other key details would you like to know in order to try to narrow down this individual's differential diagnosis? We'll just give everyone just a few more seconds. Okay, Laura, if you wouldn't mind advancing us, and let's see what folks came up with. Oh, 100% answer.
Are you able to see their responses, or do you want me to read them?
I don't see them here.
Okay. I'll read them out.
Great.
Had some folks wondering about substance use, as well
Awesome.
as any history of trauma.
Mhm.
When did the symptoms begin, and what
Mhm.
else was occurring in his life at the time?
Absolutely.
Is there a family history of psychotic disorder? Um, any current medications? Another question of, did the odd beliefs begin before he got depressed? Wondering about, has there been any decline in school or work or home functioning or activities? I've got other questions about duration and onset of symptoms, any sleep issues. Yeah, that covers it.
Wonderful. Awesome. Well, we had a wide range of answers. I feel like we don't even need to give this talk because there were so many great answers. So, yes, in terms of overall key history from our perspective that we would want to make sure that we're obtaining, you all hit a lot of them, if not almost all of them. So, of course, we want to consider previous psychiatric treatment. If the psychosis is related to a psychiatric condition, substance use was mentioned, medical history should also be obtained. And I will say duration onset is incredibly important. Part of that could include assessing for potential prodromal periods. So prodromes in the context of a primary psychotic disorder like schizophrenia are essentially subthreshold symptoms or signs of psychosis that are not a full-blown overt psychosis, but may lead to other problems like changes in functioning, people becoming more isolative or not being able to take care of themselves. So prodromes can be a little bit more subtle when we're assessing for those. And we'll probably touch on that in a couple of slides. Mood symptoms, and timing. Somebody mentioned, did the psychosis precede the depressive symptoms? So that's actually a very, very important and key aspect of the history that we will be taking some time to go a little more in depth on. Sometimes we also wonder about the characteristics of the hallucinations or the delusions being expressed, whether they are of a bizarre quality or whether they may actually be based in reality. Or something that's happened to the patient in the past in terms of like a previous trauma, for example. Are there worries based in reality? Are they realistic based on what they've experienced in the past? Or are they truly just not, like I said, based in any form of reality or prior experience that they have had? We've talked about changes in functioning, family history, safety assessment of the individual's risk for self-harm or suicide, or their history of aggression or violence towards other people is also important. I believe someone had mentioned in their response any kind of major stressors, potential triggers, or life events. And then another really important thing to highlight is collateral information. So not just obtaining history from the patient themselves, but also making sure that we are talking to whoever's at home with them, whoever their spouse is, or the most key or important people in their lives who would have a sense of how they're doing. Just another thing we wanted to mention in terms of eliciting some of these symptoms, there are a number of psychiatric rating scales. The ones listed here are all validated scales, some of which I have used myself, some of which I have not. I'm familiar with the BPRS, the Brief Psychiatric Rating Scale. For anyone who may not be entirely comfortable with how to even word or ask some of these history details, I recommend taking a look at the BPRS. They even have suggestions for how to elicit some of this information. So any of these scales are okay for you to use, but they are time consuming and they may not promote, as much of a conversational style as you would hope to have during an interview. But they're worth taking a look at if you're interested and need a little extra help with the actual clinical interview. So in terms of eliciting key history, we're going to highlight a couple, and you'll see the little blue key icon there to tune us in. So in terms of mood symptoms, affective symptoms, when we are evaluating, doing an appropriate review of systems in someone with a history of early psychosis. We just want to take a moment to talk about, as I mentioned, both major depressive disorder and bipolar 1 disorder can be associated with psychotic features. So what constitutes a major depressive episode? And this may be familiar to many of you. But we have it listed here. A major depressive episode per the DSM-5 and 5-TR is the criteria are 5 or more of the following symptoms present consistently for at least the preceding 2 weeks. And then the symptoms must include either, of course, self-evidently a depressed mood or diminished interest, anhedonia. So often with major depressive disorders or episodes, we see changes in sleep, in concentration, in appetite, and then, of course, other things like hopelessness, worthlessness, suicidal ideation in worst case scenarios. So I also wanted to briefly review criteria for manic episodes that we would see in bipolar 1. Like we mentioned earlier, psychosis is not associated with hypomania, but it is with mania at times, not always. So in order to meet criteria for a manic episode per the DSM, a patient must have 3 or more of the following criteria for at least 1 week, with the caveats that it must be 4 or more of these criteria if the mood present in the patient is only irritable, as opposed to irritable plus elated or labile. And then these symptoms can be present for less than 1 week if the patient ends up being hospitalized at any point for all of these symptoms. So mania, we'll often see poor concentration, inability to focus, impulsive or erratic behaviors that are really not characteristic of the patient when they are at their normal level of functioning or baseline. Grandiosity, big ambitions, big self-esteem. For example, a patient I saw recently who was very clearly manic, but very pleasantly so, said he wanted to create the biggest homeless shelter in the world and just to spread love and light to everyone, which was a really nice notion, but not something you would typically hear from someone during a clinical encounter for the first time. Mania, you can also see flight of ideas, which is jumping from topic to topic to topic, at times without any clear connection between the thoughts, getting to a point where you may not even remember the initial question you asked because the patient has gotten so off topic. Increases in goal-directed activities, oftentimes getting engaged in many different things and maybe not even finishing any single one of them. And then, of course, many of us are familiar with the sleep deficits associated with mania, primarily lack of sleep, with perhaps an increase in energy, even though someone may not be sleeping for days on end. And then talkativeness, increased speech, that could also be a symptom of mania. So that is that. So looping back into the clinical case that we initially presented. So for this patient, his mom did note that he was a particularly anxious child compared to her other children. It was pretty apparent that he suffered from really low self-esteem, at least since he was about middle school aged. He was diagnosed clinically with depression and anxiety around 12 years old. And to our knowledge, his first kind of suicidal ideation developed around the age of 13. He had treatment only with SSRIs, antidepressants in the past, and also some therapy prior to this hospitalization, where he presented with psychosis. So prior to the hospitalization, it was noted that his depressive symptoms seemed to worsen within the past few months after the breakup with his girlfriend. And his prominent symptoms were low mood and energy, loss of interest in activities that he enjoyed, poor concentration and sleep, and then hopelessness, worthlessness, and then these suicidal thoughts that led to him attempting suicide via the carbon monoxide poisoning. The only other things to note in terms of his mood, again, notable anxiety, particularly in social settings, with him expressing ongoing concerns over seeming stupid around other people or not being good enough. So another key piece of history that we would want to obtain would be changes in functioning. And this could be even outside of what's noted on this slide, but these are some of the more common things that we tend to look at when we're thinking about, has the patient's functioning been declining in some way? So school, were they previously a pretty good student and now they seem to be sliding more towards failing grades? Are they still going to class, or are they having trouble even getting up and going? Along the same lines with work, relationships. This could be not only romantic, but also relationships with family, relationships with friends, ability to sustain those, and concerns over increasing isolation is usually what we see in people with primary psychotic disorders. Hygiene is also another common thing that we see. Really overall self-care. When someone is struggling, keeping up with their internal world and the chaos that may be going on, they often lose touch with their external environment, and being able to take care of basic needs, such as showering, brushing your teeth, things like that. So these are all very common things that we typically see declining in someone that we're concerned about with an early psychosis. So as far as our patient, as far as his potential changes in functioning or any decline that we noted, for some months prior to admission, he did stop going to college. At the time, that was attributed to anxiety, again, due to being in social situations, having to do presentations in front of other people. Other than that, he continued his part-time work as a dog walker. Again, his girlfriend broke up with him for reasons that are unknown to us, but no other obvious changes to his overall functioning. Was still taking care of himself, was still interacting with his family. So nothing very dramatic outside of not going to school. So we have another question here. And this is the same vignette that we started with, but given the information that we have obtained about this gentleman so far, which of the following would be his most likely differential diagnosis at this point? Okay, awesome. Yes. So at this point, from what we know of this individual, his most likely differential, I agree, would be major depressive disorder with psychotic features. So why? From what we've gathered, we know that this individual has a clear documented history of major depressive episodes and major depressive disorder, which has been treated in the past. And this hospitalization, as far as we know, is the first time that he is presenting with these psychotic thoughts and features, while at the same time, he is clearly experiencing symptoms of a major depressive episode. So I would like to mention that we asked for most likely differential diagnosis. So that's why that is our answer. But at this point in his clinical evaluation, all of these answer choices should still be on his differential and should still be on your mind when continuing to evaluate him. So with that, I will turn things over to Dr. Meidl to start talking about some of those other differentials.
Yes, thank you. So this is a busy slide, but one of those options was thinking about, was his condition caused by a medical condition that could potentially be treatable outside of a primary psychiatric disorder? And so we wanted to share these two big pieces on this slide. The first big column here is discussing the medical causes that are commonly associated with psychotic symptoms. And then table 5 here is from this Freudenreich article, which we cite at the end in our references, that really talks about medical workup that should be considered for somebody with a first episode of psychosis. And this medical workup often coincides with these medical causes. So in broad base, when we think about different medical causes, epilepsy is one that often comes to mind, specifically and more often a temporal lobe epilepsy. Head trauma is also something to think about. Dementias can be associated with psychosis, specifically Lewy body, Alzheimer's, Pick's disease. And then thinking about strokes, these are more rarely associated with psychosis, but still something to think about. And then when thinking about space occupying lesions or structural brain abnormalities, this is important to consider. Is there a primary brain tumor? Are there secondary metastases? Is there an abscess? Are there midline abnormalities or CV malformations, specifically cardiovascular malformations in the temporal lobe that should be considered? When thinking about demyelinating diseases, what we think about here, though it is not typically associated with psychosis, something that is more rarely associated would be something like multiple sclerosis. In considering neuropsychiatric disorders, things like Huntington's disease come up or Wilson's disease. When thinking about the autoimmune conditions, we think about paraneoplastic syndromes or systemic lupus as well. Infections are a really big and really important thing to be considering. Does the patient have an encephalitis that could be impacting this, like an HIV encephalitis, or do they have an invasive parasitic infection like toxoplasmosis or malaria, things like this. And then herpes simplex, syphilis, things like that are things that we think about with infections. Endocrinopathies are also something to think about, including things like hyper or hypothyroidism or hypoglycemia. Narcolepsy is something in that neurologic category to be thinking about, but nutritional deficiencies are also really important, things like B12 or folate or niacin deficiencies. Metabolic disorders like porphyrias can be associated with psychosis, so those are important to consider. Chromosomal abnormalities or disorders are less commonly associated and will be pretty straight. There'll be clear options to rule out, but things like Klinefelters would be something to consider there. And then finally, toxins. We think about organophosphates that are found in like insecticides, for people who may be exposed to insecticides through farming or through other occupational hazards, heavy metals or fuels or paints. So thinking about, is there a toxin that is leading to this syndrome? And this table here discussing the medical workup really aligns with many of these conditions. Some of these, when we think about medical causes, they're really broad, and this covers very rare presentations, but it also covers some things that can easily be assessed and ruled out and treated if you find it. So when thinking about the first thing to consider to check out and do a medical workup would be that physical exam with a special emphasis on a neurologic exam. If you have a neurologic exam, that can be really helpful in ruling down some of these neurologic conditions. Also getting basic vital signs. The weight, height, and waist circumference EKG, those can be more utilized for monitoring based on what treatments we get, but can also be helpful in this diagnostic piece. When thinking about laboratory tests, helpful labs to do not only for screening for these causes, but also to have a medical baseline as we do a treatment, whatever that may be, would be things like a CBC, getting electrolytes, checking renal function and liver function tests, and getting an ESR and an anti-nuclear antibody to check for autoimmune conditions, getting fasting glucose and lipid panel just to monitor just for metabolic conditions and things like that that could be influencing the presentation or could influence treatment going forward. Similarly, considering a prolactin level can be considered when thinking about treatment or any chromosomal disorders. Thinking about a hepatitis C test if there are risk factors, getting a pregnancy test to check to see if that's going to be impacting your treatment and care, urine drug screen, checking for substances, and then thinking about that TSH, checking for hypo or hyperthyroidism, getting an some sort of syphilis screening, whether it is this FTA ABS or an RPR or another test for syphilis, just to check and rule that out. Similarly, HIV testing. You can get a ceruloplasmin test if you're really worried about Wilson's disease, and then vitamin B12 or folate, checking for vitamin deficiencies. When considering neuroimaging, MRI is preferred over CT just because it can give you just a better picture of all of the different things that could be going on in the brain, from inflammation to structural changes. And then some additional ancillary tests that you could consider if needed and if indicated for your patient would be things like an EEG or a lumbar puncture if you're really worried about seizures or an infection, karyotype screenings if you're worried about chromosomal or metabolic conditions, or heavy metal testing as well. So this is, again, a really big slide, and we're happy to, if you all have any specific questions, to talk about that more. But really, it's going to be based on just ruling things down, and many of those can be ruled down pretty quickly just by looking at their family history and doing a physical exam and looking at the background of that history. And we can move on to the medical workup that our patient got, just to kind of touch base on that more. So when thinking about what our patient did get, he did have a history of vitamin D deficiency and he had a history of GERD. Both of these were treated by his primary care doctor. He did have a complete blood count and differential done, and that was within normal limits. He also had a complete metabolic panel done, so looking at his electrolytes, his kidney function, his liver function, and that was all within normal limits as well. His thyroid test was within normal limits. He had his HIV and RPR testing done, which was negative. He had a B12 and folate done, checking for vitamin concerns, and that was good. And then he got an MRI without contrast, and there wasn't an abnormality noted. So there were no concerns there. And EKG was normal, so allowing us to be open with any sort of antipsychotics that we may need, or antidepressants that we may need, or other treatments. And then the next thing that we really like to think about that goes really well with medical causes, and we already talked about getting a urine screen, and really we want to think about substances that can be inducing psychotic symptoms. So the DSM describes these substances as substances that can impact psychosis and cause psychosis. So those include things like cocaine or amphetamine type substances or other stimulants, hallucinogens, phencyclidine or PCP, cannabis, inhalants, sedative hypnotics or anxiolytics. And then I really wanted to create a category of other. Other is listed in the DSM, but when we talk about other, it's really broad. So there are a lot of prescribed medications that can impact psychosis, corticosteroids, chemotherapeutic agents, levodopa if you're treating somebody with Parkinson's disease. I mean, there are a lot of things that cause this. So really thinking about that medical list critically, and can any of the medications that they're already prescribed be influencing this condition? And then in thinking about what a substance, if there was a substance that did show up on that urine screen, thinking about what it really means to have a substance or medication-induced psychotic disorder, I think is important, because it can be something that's usually asked about, and we have to think about carefully. But this is when you do have presence of delusions or hallucinations and evidence that these symptoms developed during or soon after the intoxication or withdrawal of the substance or medication, and that substance or medication is capable of producing those symptoms, and that it's not better explained by another diagnosis, and that it's not exclusive to the course of delirium, and it's also impacting functioning. So it's leading to some functional impairment. And I get a lot of questions about the timeline of this. You know, if there was a substance, when is it no longer a substance-induced disorder? Or what is that timeline, and what is that really? So we get some clarity here, but then the DSM goes on to describe that the symptoms that happened prior, if symptoms happened prior to the substance or medication use, or symptoms are continuing for a substantial period of time, about 1 month or greater, following the cessation of the substance use, or the acute withdrawal, or severe intoxication, then this would rule up a primary psychotic disorder. Or if there's evidence that the patient had symptoms prior to the substance use, or episodes outside of the substance use as well, that would also rule up a primary psychotic disorder. So I think a lot of questions come up around the timeline of this. And so I just wanted to clarify that. So he had a urine tox that was negative, and his patient, and he and his family denied any history of substance use. And then the next thing that Hena already really talked about, and you all brought up too when thinking about this case, is the timing, and considering the symptom onset across the lifespan when considering our differential for psychosis. And so I actually want to start at the bottom of this graph, with our schizophrenia. For a diagnosis of schizophrenia, it does have really specific time criteria. So the symptoms that you're going to have 2 or more of these specific symptoms below here that are numbered. And these are going to be present for a significant portion of 1 month. And at least one of these symptoms must be number 1, 2, or 3. And these are considered the active phase symptoms of schizophrenia. So 1 could be delusions, 2 is hallucinations, 3 is disorganized speech. So the patient must have at least one of these during that active phase. They could also have, though, disorganized or catatonic behavior, or negative symptoms as well. And these symptoms are associated with significant functional impairment. And that time piece, there's always a caveat in the DSM where it can be less if treated. So if they're getting an active treatment, then there's always that caveat. But these symptoms are present. And for that diagnosis of schizophrenia with its time criteria, those are going to be continuous signs of illness that persist for at least 6 months. And you're going to have 1 month of active phase symptoms. So you still need that 1 month with symptoms in the 1, 2, or 3 category. But then you're also going to have symptoms that may not reach that threshold of as significant as that 1 month time frame. And those are going to be lasting for 6 months. In considering the next one up, that really allows for that differentiation between schizophrenia and brief psychotic disorder, is the timeline pieces. So with are schizophreniform, you're still going to be having this criteria of schizophrenia. You're going to have 2 or more of the symptoms of schizophrenia, but the timeline is going to be different. That's going to be greater than 1 month and less than 6 months timeline. And then for a brief psychotic disorder, that timeline is going to be different as well. The symptoms are going to be 1 or more of the symptoms of schizophrenia, which with 1 must be 1, 2, or 3. So it must be either delusion, hallucination, or disorganized speech. And you're going to have these symptoms for more than 1 day, but less than 1 month. And then there will be eventual full return to the premorbid or prior level of functioning. And so that timeline can really be helpful in thinking about what type of psychosis is this? Is this a schizophreniform, a brief psychotic disorder, or is it schizophrenia? I also wanted to highlight in this slide a delusional disorder. One, because it also has a timeline that's specific, but I think its symptoms are also important to think about. So for delusional disorders, you're going to have symptoms that last greater than or equal to a month. And the symptoms are going to be 1 or more delusions. And these are usually non-bizarre delusions. Dr. Yakoob brought up that as a question between bizarre and non-bizarre. So usually these are non-bizarre, and daily functioning is not going to be significantly impaired. And it's not going to meet the criteria for schizophrenia as described in this bottom row here of our table. And then in considering timing as well, in addition to just thinking about the length of time of the episodes, if you have a patient who has mood symptoms in addition, another thing that's going to be really valuable to think about is schizophrenia versus schizoaffective disorder versus a major depressive episode with psychosis or a manic episode with psychosis. So over the next 3 slides, I wanted to just map out a patient's lifespan and how thinking about the timeline of a patient's life can be helpful in differentiating these conditions. So a key with a schizoaffective disorder is that you are going to be meeting you are going to have a period of time where you're meeting criterion A of schizophrenia. You're meeting that 1 month of active phase symptoms of schizophrenia. In addition, you will also at that same time, at the concurrent time, meet criteria for a major depressive episode or a manic episode, as Dr. Yakoob described, with meeting criteria for schizophrenia as well. And then after the mood episode resolves, you are going to still have at least 2 weeks of psychosis without those mood symptoms. And when thinking about the duration of illness across the lifetime, you are going to have a significant portion of a patient's life where they're experiencing or receiving, treatment and having some residual symptoms of psychosis. And they're also going to have a significant amount of mood episodes throughout their life as well. And that's what can be really helpful to map out and think about when we're thinking about these timelines. And on the next slide, we think about a major depressive episode or a manic episode with psychosis. And what's important here to help in differentiation from schizoaffective disorder is those psychotic symptoms that you have concurrently with a major depressive or a manic episode. Those are going to be resolving with the mood episode when that's resolving. Unlike in our last slide, when we talked about schizoaffective disorder, those psychosis symptoms are going to stick around in schizoaffective disorder, while they won't necessarily stick around in the major depressive or manic episode. And then in the last slide, I wanted to just highlight schizophrenia over a lifespan. So I think that this can lead to questions too about how do you know if they have a mood episode, is it now schizoaffective disorder? But a key feature of this is that In schizophrenia, if the mood episodes have occurred during active phase symptoms, they've been present for a minority of the total duration of active and residual periods of the illness, unlike in a schizoaffective disorder, where it's happening much more than the minority of the time. So you can absolutely have a depressive episode and schizophrenia. But you really need to think about how much the mood episodes are impacting a patient's life to really understand that diagnosis.
All right. So taking it away back to our clinical case. So after he was discharged several outpatient visits later, he ends up revealing that when he was around 16, he recalled receiving messages from God for a period of about 3 to 4 months, during which time he also remembered feeling more spiritual than usual and also more superstitious, making odd connections between things, saying things like, if God thought I did a good job, it would make my stocks better, doing other odd things like picking up a lot of lucky pennies. These experiences slowly faded over time, but he did say that he felt that they still lingered somewhere in the back of his mind, and he didn't quite understand what was going on. Because of embarrassment and not wanting to talk about what he was experiencing at the time, he essentially kept all of this to himself until he reveals it in your outpatient visit with him. So timing is super, super important in this case. And in terms of just wrapping up his case, while he was hospitalized, he was stabilized on both olanzapine and bupropion with 100% resolution in both his mood and his psychotic symptoms. After a few months, he wanted to try another antipsychotic due to, unfortunately, a lot of weight gain associated with the olanzapine. And then throughout his treatment course, he ended up experiencing a recurrence of really distressing psychotic symptoms when attempting to switch to another antipsychotic, aripiprazole. Of note, during this time, he did not have a notable recurrence or predominance of his depressive symptoms from before. So, another question to round us out. At this point, given the information we have obtained in this individual's overall clinical examination, now what differential diagnosis do you think is most likely for him? Okay, wonderful. Oop. Yes. And we can talk about this more, but essentially, this case really highlights the importance of duration and onset of symptoms as well as timing of symptoms. For this case, he ended up having psychotic symptoms much earlier than we had thought. And we may have, in fact, missed essentially a prodrome. And although his symptoms at 16 could have coincided with a bout of depression at the time, we're not sure. His clinical picture only really became clearer to us after treating him for several months and observing his trajectory with medication adjustments. And so given that his mood was stable, again, while psychosis became more predominant during the antipsychotic cross titration, he really did appear overall more consistent with a primary psychotic disorder like schizophrenia. And so this leads into our last and final objective for this talk, is highlighting the incredible importance of ongoing reevaluation of a patient's diagnoses, regardless of what your first impressions are of them, or regardless of what diagnoses they came to you with. It's just so incredibly vital, especially in our early psychosis, our younger patients who often get mislabeled and misdiagnosed, and then potentially, treated not appropriately for years and years on end. So we have to be very vigilant about this and also understand, hopefully it's apparent throughout our discussion of this case and his workup, that you're not going to have all the information after just one visit. It's very, very difficult to do. So these things take time. Forming your differential, narrowing your differential, definitely takes time. And with this individual, I think this is based on a real case that we've had. It took a solid 6 months of outpatient treatment with us before his diagnosis was changed to a primary psychotic disorder. So that is all that we have. Dr. Meidl, did you have any other comments you wanted to tag on?
I did not. Thank you so much for the wrap up.